Hi, and welcome to the Muslim Sex Podcast. This is Dr. Sadaf Lodhi, and I would love for you to leave me a review of this podcast and also to share and like it and share it with your friends. See what they think and let me know. I would love to shout you out on social media. And also, I would love for you to follow me on Instagram at Dr. Sadaf OBGYN, as well as TikTok. I also have started a YouTube channel at Dr. Sadaf Intimacy Coach. I'd love for you to follow me on all of those channels. And most importantly, I'd love for you to become a patient. I am now accepting telehealth patients for sexual health as well as menopause health in New York and Michigan. So if you are a woman that is looking for a doctor that understands you and can actually take the time to listen to all of your concerns, reach out to me. Reach out at Dr. Sadaf at drsadaf.com. And I would love to see you as a patient. And now for the episode. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf Lodhi, and this episode is everything you need to know about female sexual dysfunction and why sex hurts, and you get to meet the famous Dr. Irwin Goldstein. So before I get into it, the first thing I want to make very clear is that I'm not giving any type of medical advice. So if you're having any health issues, please speak with your friendly neighborhood healthcare provider. And if you have any questions about your religion, please speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So I am super excited to have on with me today Dr. Irwin Goldstein, who is coming to us live from San Diego, California. So
Sunny and 70.
That's not what it is in New York, that's for sure. And
Well, I'll show you. Here's trying to get the damn sun out of the way, but it's too much.
yeah, I wish we had that problem here. It's rainy. But I am so excited to have you on, and I would love for you to introduce yourself to the viewers and the listeners out there watching this, and just let them know a little bit about yourself and what inspires you to do all the research and all the work that you've done on female sexual medicine.
Wow, what a fabulous introduction. Thank you. Well, I don't know how to introduce myself. I'm just regular old guy that loves what I do. I started.
Very humble. Yes.
I'm from Montreal, Quebec, Canada, so I'm not American. Although I sort of became an American, but not by birth. I played hockey all my life. I love electrical biomedical engineering. I became an electrical biomedical engineer, and I played hockey in college. And I met Sue. Those are my three great treasures. And the Vietnam War was going on when I was doing all this, and it was kind of a sad place for engineers. There were no job opportunities, no job listings, and it was kind of sad. And I went home my junior year for spring break, and I came back a physician. My family convinced me that I had no future in engineering, which was probably correct at the time. And I spent the summer of my junior year doing the pre-med courses that I had no idea that I even was interested in doing. And I don't know, I have a brain that's not normal. I view everything as puzzles, and I have to solve them, and that's my engineering background. And medicine is this very cool field that is just so broad and so involved, but it involves human beings and bother and distress, and we have the opportunity to help them. So it's like this really cool place for an engineer to find themselves. And I went to medical school, and every place I went to, I did a session in cardiology. Well, I wanted to be a cardiologist, and I did a session in OBGYN. I said, well, that's for me. Delivering babies, how much fun could that be? And then I went to urology. I said, I want to be a urologist, and everything was the same. But urology was this cool place where you would have a patient in front of you. You could listen to their story and do diagnostic tests. And then rather than saying, well, I'm only a diagnostician, I'm not a surgeon, I have to send them to somebody, urology, you're both this combined diagnostician and therapeutic person. That's a remarkable blessing
Right.
where you cover both areas. So you really are in charge of the patient. And a cute story, I was in the emergency room one day, and you were assigned sort of a loading place for the ambulance. So whatever I was, room 3 or something, and a patient comes into room 3 and comes out screaming and yelling and uh, like awful, and he couldn't pee. He was in
Mm,
urinary retention, and his
yeah.
abdomen was full because his bladder was full of urine, and he had what's called a stricture. He had a blockage in the urethra, the tube
Oh.
in the
Mm.
bladder and the outside world. And of course, we couldn't help him. You need to get urology. So we got urology on the phone. And in a few minutes, a bunch of people came down. They were smiling, they were laughing. They had this bag of tricks, and they figured out how to get a tube through the blockage, and his urine retention was drained within a few minutes. And he said, "Thank you, oh, thank you." I'll never forget that scene,
Yeah.
because in medicine, you work for hours on people, but you don't always get the thank yous. Uh,
That's
but
sure.
saving someone in urinary retention by allowing him to drain his urine is pretty remarkable stuff. And I said, "Wow, I got to do that field." So I went into urology, God knows, and my chairman, of all things, the penile implant. This goes back to the original. So the original penile implant, United States of America, was 1973,
Oh,
and
wow.
my doctor went to Houston, which is where it was developed, in 1974, and became the penile implant doctor for the region where I was, which is kind of
Wow.
east of the Mississippi.
Yeah.
So I was starting in urology and working with the professor who was working with people who couldn't get erections, and nobody knew why, and nobody actually cared why, which was really awful. But they had a solution. They could put this device in, and
Hmm.
he became the device dude of the East Coast. And I was working with him, and I made a very fatal mistake one day saying, "I don't understand how an erection works in the real place. How does that happen?" He said, "Dr. Goldstein, we don't care. We just put these devices in if it works." And I said, "Okay, somebody has to care." And then,
Right.
why wouldn't people know how an erection worked? That seems so ridiculously silly to say we don't care. So I got NIH grants for 25 years to help figure out how
Amazing.
erections worked, and we had a big lab, and we were well funded. And that's another irony. It's easy to be well funded for male sexual dysfunction. It's
Yes,
impossible to be funded for women's sexual function. Just
I
kind of
know.
an irony that I'll place it before your eyes. Anyways, in 1991, after more than a decade of trying to understand what was the chemical released when you, with your eyes, stared at something that was sexually attractive to you, that resulted in your sort of penis getting into the erect state, we couldn't know what that was. It was the most difficult investigation, but we finally figured it out. And God only knows, it was a gas. Who would have thought that your
Yeah.
nerves released a gas? The gas was called nitric oxide, OXID, which, think about it, nitrogen is the most plentiful thing in the air, and the next most thing is oxygen. So if you think of reproduction and our world, it has to be kind of elemental. And I guess we weren't thinking about all that when we started this, but
It's
nitric
amazing.
oxide came out, and that was the early 90s. And if kind of as luck would have it, there was a pharmaceutical company in England called Pfizer Pharmaceuticals, which was working on a drug called a phosphodiesterase type 5 inhibitor, UK 92480, which was the preliminary name for Viagra.
Oh,
Uh,
wow.
Viagra was a phosphodiesterase type 5 inhibitor, which is in the nitric oxide pathways further down the system, and they were studying it for angina, difficulty with pain because not getting that much blood to the heart. and it
Right.
wasn't all that successful. But in giving the medicine to the patients who had to stay overnight and get tested for blood levels in the morning and side effects, they were all waking up with morning erections, and that was pretty intense. And as the project left the primary indication for angina, it took on its new role for erection and was incredibly, remarkably effective with essentially no side effects. And billions of years later,
Yeah.
we're now on the 25th year of this.
Oh, wow.
It's 1998 it came out. So today's 2023. It's 25 years.
Yeah.
But in 1998, it happens to be on May 14th, if you want to remember, May 14th, 1998, the New England Journal of Medicine presented to the medical community around the world the first ever phase 2 and phase 3 data on the drug Viagra. And we were horribly invested with Pfizer on the basic science element. We studied the nitric oxide release in the clitoris, and it was obviously very involved in there too. And for reasons that I'm not 100% clear, I was the first name, the first author on this pretty remarkable paper. So I was the corresponding author. So my office, we didn't have
Yeah.
cell phones in those days, computers were minimal, and people just phoned people if they wanted information. So we got thousands and thousands of phone calls over the next bunches of weeks to months. And I'll just point it out to you. If you had to pick and choose what the gender was for all these phone calls, you may think gender one, but it's absolutely the wrong answer.
No way.
Yeah,
So
it's,
it wasn't so it wasn't men that were calling you?
no, it was absolutely not men. Well, men had their answer. Women were saying, "Hey, Dr. Goldstein's fabulous article. I have an arousal problem. I'm a woman. I
Ah.
go to my gynecologist. Nobody helps me. Is this for me?" Or next one was Dr. Goldstein. I am not interested. Dr. Goldstein, I can't have an orgasm. Dr. Goldstein, blah, blah, blah. And I said, interesting. I'm a urologist. Okay.
Yeah.
I do men's sexual function. It's got to be that gynecologists have a track in sexual medicine as we did in urology for men. And I
That's
was dumbfounded to find
no,
out
we don't have anything.
it wasn't even that they didn't have a track. It was kind of suppressed, the whole sort of investigatory pathway, and the therapeutic pathway was not a priority.
Yeah.
So, in this was in May 14th, 1998. By August, we already started seeing women. I had no idea what I was doing, but we sort of treated them in our model. So our model was biopsychosocial, 3-hour visits, intense examinations with a psychologist, intense investigations of hormone levels and neurologic levels. Essentially, what we were doing for men, we just say, "Hey, I don't know what I'm doing, but I'll just do what I'm doing for men for women, and we'll see where that takes us." And
Yeah.
I have to say, we were seeing 50% men and 50% women by the fall of 1998. It was just
Wow.
so overwhelming with the need.
Yeah. Yeah.
And that's been in my life going forward. One of the fallouts from this was I looked at my wife and I said, I really don't know what I'm doing, but obviously there's a need. We
Yeah.
need to form a group of people who are more expert than me because I knew nothing. And
Yeah.
we started ISWISH in 1998.
Oh.
We're on our 25th year of ISWISH. It wasn't called ISWISH at the time, but eventually became ISWISH, I think in the year 2000 or something like that. But and we got people together who were neurologists and who were psychiatrists and who were sex therapists and who were gynecologists, who were whatever, whoever was interested came. And our first several meetings, we had 1,000, 1,200 people come. It was quite amazing. The
Yeah, that's
need, the people, once there was this place, the, you build it, they will come concept came to truth. And now ISWISH is this amazing place, International Society for the Study of Women's Sexual Health. So I wake up every morning and I have this sort of passion about trying to provide people with sexual health issues a better life quality. and I don't care about the gender, and we do what we can. And to me, everything is a detective's game. And I have the chance to spend many hours with people and try to understand it. And we've described a whole bunch of conditions that have ended up helping people. But boy, oh boy, we are just the beginning of this iceberg thing. And there are gazillions of sex issues that need better understanding.
Well, that is
Stop there.
amazing. Yeah, I had no idea that you were involved with so much research. I saw actually online that it says you have 350 articles published. Is
We're
that
up to 380 something now.
Oh my goodness. Wow, that's amazing. And so your research, the articles that you publish, are they both? Are they both for men and women, or do you focus more heavily on one than the other?
Well, up until 1998, other
Yeah.
than animal models for women that we were just kind of having an interest, but not really a focus on, it was all for men.
Yeah.
But I would say since 1998, my passion is for women, but my reality is there's a lot of conditions for men that are absolutely. Let me give you a little a cute story. So we had a guy call us, and he says his penis, which normally hangs down and just gets out of the way, was shriveled like an accordion deep inside his body,
Oh, wow.
and it was painful and unhappy and bothersome, and he couldn't urinate and he couldn't defecate, and his testicles, instead of hanging down, were up against his scrotum. And if you actually watched his scrotum, it would go like this, like a lava lamp. um, and I said, okay, this is fascinating. This is, to me, the first sexual health problem in man that wasn't about penile erection in
Right.
penis. It was about in the flaccid state in penis. And
Interesting.
after a lot of research, I worked with a bunch of people to better understand this. There is a nerve called the hypogastric nerve. It's the nerve
Right.
that's involved in getting rid of the erection when you finish with sexual activity. You get rid of the erection by activating the hypogastric nerve. Well, this condition has the not so perfect name as hard flaccid syndrome, and the acronym is HFS. And it is
Wow.
a really devastating problem for people who have it. Is the result of excess sympathetic activity, the fight or flight activity,
Right.
in the efferent, the motor, hypogastric nerve. And something is triggering the hypogastric nerve to constantly fire. And it's basically everything I mentioned is just hypogastric nerve symptoms.
Right.
And we're now identifying strategies to treat it, and blah blah blah. My whole point is it's the detective story for people. Like I know you know about persistent genital arousal disorder. And
Yes.
that
Mm.
was yet another detective crazy story that we've been working on, and on and on. But it just goes, it doesn't stop. And I could give you 10 more that we still haven't figured out yet, that I'm really, there's a condition where men, particularly in men, will have an orgasm. And as all men, unlike women, which have the great opportunity to have multiple orgasms and sort of be adrenalinized as a result of orgasm, men have one orgasm and they enter a very low dopamine state, a very high serotonin state, and they're like snoring and sleeping in 4 microseconds. You can't move them, you can't rouse them. They're just kind of dead. And then that refractory period ends, and then you resume back to your world. But in some people, it takes 7 to 10 days for that
Yes.
refractory period. They are a mess. They have brain fog. They can't function. They can't move. They're depressed. They're sad. That way for 7 to 10 days. They can't hold jobs. They can't do
Wow.
work. They can't. I mean, it's just an awful, awful condition. So it's a prolonged post ejaculation refractory period. It goes under the name currently of post orgasm illness syndrome, but
Ah.
it's not a really great name, and we'll probably have to rename it at some point. But We don't know how that works. I'm trying desperately to help people who have that, but it's another puzzle part. It's kind of like sexuality is this amazing biopsychosocial brain, uh, hormones, nerves, vascular anatomy thing that affects so many patients,
Yes.
and we've managed to examine 10% of the complaints that people have,
Yeah.
and uh, yeah, we're slowly getting there.
Yeah, no, that's crazy with all the things that you've discovered. What I've noticed is that actually a lot of your research, or at least recently when you were last talking at the Ishwish meeting, it deals a lot with the spinal cord
Right.
and innervation and nerves and all the regions that you define in terms of trying to figure out where the pain or the problem is stemming from. And I find it fascinating that you have divided that up. And maybe you could talk a little bit about the regions, or how you, when you see a patient that has sexual pain, let's say it's a woman, and how do you go about defining what those regions are, and how you go about examining that patient?
So Mary will walk in the room, distraught, frustrated, probably has seen 10 previous providers,
Of course.
at wit's end,
Yeah.
partner at
Mm.
wit's end with Mary, but supportive. And she'll say, I have this unbelievable electric shock, burning, itching pain in my clitoris or in my
Mm.
labia or
Yeah.
deep in my vagina. And I have a golf ball feeling inside my rectum. And, all these unusual, we call them dysesthesias, not to
Mm.
confuse the reader or the listener, but the word aesthesia is to feel, and dysfunctional feeling has been termed dysesthesia. So we're toying with the term GPD, which would be genitopelvic dysesthesia. So someone with pain in her clitoris or other regions is a genitopelvic dysesthesia.
Right.
So you know, so the clitoris has to be perceived of in the brain. So you touch your clitoris, you go to the brain. You touch your vagina, you touch your labia, you touch your rectum, you touch your thigh, you touch your toe. It all is end up in the brain. So how does it get to the brain? Well, it has to pass through a bunch of way stations. I mean, it's either at the level of the genital, and we call that region one, or between the genital and the neurologic system called the central nervous system. That would be the pelvis perineum. That's region two. In region three, which is the lower part of the spine, you can examine it easily with what's called a lumbar, lumbar MRI. You can also do what's called a sacral MRI, but that gets even lower in the
Yeah.
lower spine. So we suggest a lumbar MRI. We also suspect a few caveats that it's at least a Tesla 3. That means at least with appropriate magnet strength. And we don't need contrast, which is kind of sometimes dangerous for people. So a Tesla 3, and it has to have both sagittal and axial views, so this way and this way, MRI, which is pretty standard. And then if something pops up on that, we do what's called neurogenital testing. We also do what's called regional anesthesia tests. It's kind of fun. So if the woman says, for example, my clitoris is on fire, I have a ring of fire right around my clitoris, it's the most annoying thing on earth, etc., we'll take an anesthetic agent and numb the clitoris. So if we numb the clitoris and the pain continues, well, that's obviously not from the region one genital area. So we
Yeah.
say, well, maybe it's region two. So we'll go to the pudendal nerve, whatever. And if the pudendal nerve is maybe a little tender, we'll numb the pudendal nerve. She said, oh my God, Dr. Goldstein, will you stop with all these needles? Because nothing's affecting my clitoris. It's still firing away. So we'll say, well, maybe therefore it's closer to the brain now in region three in the lower back. So we get an MRI and she says, oh my gosh, you have an annular tear, a kind of slip
Mm.
disc situation where you're irritating what's called a nerve root in the spine, and the nerve root could be actually representing the sensation of the clitoris. So
Mm.
we would stick a needle with lidocaine, as we did in the clitoris and the pudendal nerve, we would stick it in at the level of the pathology in the lower back area. And she said, "Oh my God, all my pain went away." And we'd say, "Wow, so we've identified now the trigger. Now we can put together a plan to help you." So it's all of this detective-y sort of stuff where you say, if you have a pain and discomfort or dysesthesia, if you find where it's coming from and you numb it and it resolves the issue temporarily, well, at least you've identified where the trigger is.
Right.
And it's just all of that stuff.
It's amazing. I think that there is so much information that you present in sexual medicine. And when we did that Ishwish course, that we just don't get taught in medical school, definitely not in medical school, and not even in OBGYN residency. I mean, we don't even talk about sex in OBGYN residency. And so, really, like, where are you supposed to learn all this information? I think it's only by going to these courses do you even know about all of these different things that can happen and the treatments and how you really assess a patient. I mean, it's really unfortunate, I think, for patients, because they come to us, seeking help and seeking answers, and we're not even able to help them at all because we haven't been trained and we don't have that information. And I was reading the book that you co-authored this one, and I know it's not the most recent one, but it's a very good book. And you talk about how so many women are dismissed because they, people think they're crazy, or they just need to relax, or they just, they're too tense, and really do not get their symptoms or even anything looked at or addressed.
So the fundamental point you're making is that there needs to be some group that takes this project on in a real passionate scientific way. And that is ISWISH, International Society of Study of Women's Sexual Health. There is no higher level international group that dedicates itself to women's sexual health study, diagnosis, and treatment.
Yeah.
It's not coming from gynecology, but it's not even coming from urology. It's not coming from radiology. It's not coming from internal medicine. It's
Yeah.
coming from those subgroups that are actually, for whatever reason, have a virus that makes them interested in women.
Yeah.
And I'm stuck with that virus. So I'm very happy to do that.
Mhm.
Maybe one day ISWISH will expand into the gynecology community more open. I mean, it's only 25 years old. Maybe it'll take another 25 years, but
Yeah, who knows?
at least it exists, and all the research in the field is being funded through ISWISH. All the detective areas are being funded. Like, we have a journal. ISWISH journal is called the Journal of Sexual Medicine. It's called Sexual Medicine, and it's called Sexual Medicine Reviews. We have three journals. And
Wow.
I've been editor of two of these journals, which has been really a fabulous opportunity to teach and to learn,
In your
and
free time?
in my free time. And I have one more year left on one of the journals. But listen, it's not that it doesn't exist. You have to do a kind of bit of research and find an ISWISH sort of situation. And if you're a provider listening to this podcast and want to help, please join. We have patient advocate portions of ISWISH to join. But I always tell people this one story. It's kind of a sad story, but it's the truth. I had a PhD from Switzerland who flew to work in Montreal, Quebec, Canada, where I'm born, for 1 year doing her PhD, but she was supposed to do 2 years. But she ended up completing the PhD in 1 year. And I get
Wow.
this phone call from colleagues in Montreal saying this woman would be honored to come spend the next year in San Diego. Well, of course, the weather is way better
Yeah,
than in Montreal.
that's
And I
right.
said
Who wouldn't be on? Yeah.
I would love for her to spend a year with me. So she arrives and we shake hands and blah blah blah. And then she sits in a sort of a chair next to me as the patient comes in. The patient gives permission, so she sits there. And the patient has clitoral hypersensitivity. I'll never forget this. The very first patient she sees had clitoral hypersensitivity. So the partner could touch nearby, but the partner could not touched directly on. And it was kind
No.
of frustrating for them both. And worse was the non-sexual thing. She couldn't wear tight pants with the seam in it because the clitoris would get
Right.
sort of contacted by that. And
Mm.
when we brought her into the room and the PhD was with me, we examined the clitoris. And I'll use my hand here. So if this is sort of the head of the penis called the glans, and this is kind of the hood or prepuce or foreskin. In clitorises, it has the word hood. In men, it's called the foreskin, but same thing. But it's supposed to retract back and forth. But in some women, it attaches. And
Mm.
when we looked underneath the attachment, you could kind of see these what we call keratin pearls that irritate the skin and cause the hypersensitivity. So we did a procedure on her. We numbed the clitoris, and in about 15 minutes, got all these adhesions away, and everything was fine. And she was so happy. And I went to the PhD and I said, "Okay, I think you have your project. We don't know anything about this. How many women have this? What is the
Yeah.
correct management for them? What are the characteristics of this that make this even happen?" So she spent the year doing it. We, of course, examine everybody in our model where their physical examination is present on a big plasma TV, high definition in front of them. So everybody gets to see their anatomy. We think it's
That's
just
excellent.
awful.
Yeah.
And I'll say the word awful in it with all capital letters, that women don't get to see what the doctor is seeing. I think that's just unfair. I examine people, their arms, they stare at their arms as I stare at their arms.
Right.
Why
Right.
can't a woman see their genital? It's really not complicated technology to allow
Yeah.
them to see what we see. However, so we do that regularly, and we take photographs. So this woman went through 1,200, I'm going to say 61, but it's close to that, photographs of women's clitorises. I mean, we photograph everything, but among the important area for this topic, the region of the clitoris was considered. And among the 1,200 photographs that we all looked at, we found about 680 that were relatively good focus and for which we could make a decision if this situation existed for the hood to be attached to the clitoris. And we found, do you know the number we found?
No, tell me.
I'll
Really
send
excited.
you the article. It's really a heavy duty, groundbreaking thing. 23% of women have attachments, of which a smaller percentage, 14%, have hypersensitivity. So a lot of people have it. More women than men have hood or prepuce or foreskin problems, but it's just not known. No one looks, no one sees. So in writing the paper up, we went to 3 or 4 classic gynecology, like you would know these classic gynecology textbooks. They're like 4 inches wide of information.
Yeah.
So they
Yeah.
have a teeny article chapter on the word clitoris,
Yeah.
and I said, okay, let's read how gynecologists do a physical examination. Let's see if it's different than we're doing, because I had never read a gynecology textbook on it.
Yeah.
What do you think it says in every one of those textbooks about examining a woman's clitoris?
Nothing. It says nothing. It says we don't
Well,
examine them.
actually, it says something. It
Oh,
says
what does it
don't,
say? Don't.
don't examine a woman's clitoris. It's
Why?
Pandora's box. You don't have time. You'll get involved in questions and blah blah blah. So can you imagine a
No.
provider telling another provider there's a body part you're not allowed to examine? But that's what it said. I mean, I swear to God that we took it straight out of the textbooks, what the paragraphs were that says don't examine a woman's clitoris. A little shocking, but there you go. That's where it's all coming from.
That's ridiculous.
So we reported on the adhesion thing as yet another detective's game and all of this stuff.
That's amazing. Well, I'm really grateful for you and for all the work that you've done in this field of medicine and to bring women's sexual health to light and creating the International Society for the Study of Women's Sexual Health and all the work that you do. I mean, you are lovingly
Back at
called.
you. Back at you. Thank you for these podcasts. Thank you for teaching the real end person. Thank you for spreading the word, because it's one thing for us to write papers 400 papers. They sit in PubMed where no one looks at them, but somebody has to bring it to the population, and that's all about you. I don't do these podcast things. That's one more thing for me to consider, but I don't get it to the masses, and you do, and that's way more important. So back at you for thanking you.
Oh, no, thank you. So, well, we are done here, and it's been real and really intimate. But before we go, Dr. Goldstein, what if there is a person watching this, listening to this, and they're like, oh my God, he is so amazing. How in the world can I get in touch with Dr. Goldstein? How can I figure out where to go if I need some help? And I think, I may have something going on in my spine and no one else is listening to me. How can they get in touch with you?
It's actually not that complicated. We work at this amazing 6,000 square foot facility with psychologists, physical therapists, nurse practitioners, MAs, and the like. And it's
The
called San
dream
Diego.
facility.
It is my
Yeah.
dream. There's no question. San Diego Sexual Medicine, SDSM, San Diego Sexual Medicine. And then you can call. We do what are called courtesy calls. So no one can come to us without us speaking to them free to find out where their needs are and if it's appropriate, because most people are from out of state.
Right.
And we just want to make sure their travel has realistic expectations and all that. But I see, if I'm lucky, 4 patients a day because it's 3 hours per. And
Wow.
but typically are complicated and typically are joyful to sort of figure it out.
Wow. Amazing. Well, thank you again for all that you do. And remember, this is not meant to be any type of medical advice. So if you're having any issues, and definitely if you're having any sexual health issues, make sure you seek out Dr. Goldstein, because he is the godfather of sexual medicine. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.
This show was produced by Pretty Easy Podcasts and made possible by listeners like you. If you ever thought of doing your own podcast, please visit prettyeasypodcast.com.